These are our objectives. We're going to talk about what the difference between DI and SIADH is. And then we're going to discuss treatment goals for them because there's two completely different opposite disease processes, if that makes sense. So we're just going to do a little bit of anatomy starting off. So we're going to start with the pituitary gland, which is located right here. So this is your hypothalamus. It is located right underneath. This is your cerebrum, so your brainstem, and then the brain. So it's recessed in the base of the cranium, not accessible for physical assessment, so you can't go and assess your pituitary gland if you wanted to. It regulates most endocrine functions, so there is an anterior and posterior portion. So your anterior releases oxytocin, which you guys are in OB right now, so you can tell me what oxytocin is. Yeah, it contracts the uterus. It's just unhappy, helps contract the uterus. So that is an OB thing. We will not be talking about that in critical care. And then we have your posterior, which is what releases your antidiuretic hormone. So just using our context clues, what is antidiuretic hormone? Yeah, retaining water. That's exactly what it is. So if you saw ADH on your exam and you had no idea what it was, even though my goal is for you guys to know what it is after this, you can use your context clues and be like antidiuretic, so it's going to retain water. So there's two disease processes that affect this, that your antidiuretic hormone affects, and that is called DI, so it's diabetes insipidus. I'm going to shorten it to DI, so if you hear me say DI, that is what I'm referring to. And then we have SIADH, which we will talk about that in a minute. So there's two, so it's fluid volume deficit, fluid volume excess. So you either have too little ADH or too much ADH. So just simply put, if you have too little ADH, what do you think that means? Yeah, they're going to be dry, right? Too little antidiuretic hormone, you're going to be dry. And too much antidiuretic hormone, you're going to be retaining water, so you're going to be overloaded. So that is your difference between your DI and SIADH. And we'll go into further more, but does that kind of make sense? All right, antidiuretic hormone, it is also called vasopressin. So you will also hear it interchangeably called vasopressin. Again, it's produced in the hypothalamus. Which portion? Posterior, good job. And it says it on the slide. It is released primarily in response to elevations in serum Oz. So I'm going to shorten osmolality to Oz. That's what you also hear in the clinical setting as well. And secondarily in reaction to hypovolemia and hypotension. So how this occurs is your kidneys, so you have your renal tubules. Your kidneys and your renal tubules will start retaining water. So instead of filtering out the water, this ADH is released and it tells your kidneys, hey, stop, we need to keep this. So that's how it retains in the renal tubules of your kidneys. By regulating water and electrolyte balances. The purpose is to maintain normal serum osmolality and circulating blood volume. Well, when you have an issue with these two, when you have an issue with your ADH, too little or too much, no matter how perfect your kidneys are working, sometimes it just can't either excrete or retain the ADH. So some nursing priorities prior to we talk about the disease process is you want to assess hydration status. Why? Say it loud. Yeah, so your assessment, your skin assessment is very important for these dehydrated patients. So assess skin integrity, assess skin turgor, mucous membranes, urine output via Foley. So what would be some clinical symptoms that a patient has poor hydration status? Skin tinting. What else? Dry mucous membranes. Low urine output, less than 30, right? What about if you are overloaded? Edema. Might hear crackles in the lungs. Weeping, yeah. So that's kind of knowing your pathophysiology prior to even knowing these disease processes will help you be able to clinically place these. Neurocheck. So, what sodium do you, I just gave the answer. Oops. What electrolyte do you think, if you get this wrong, guys, what electrolyte associates with your neurostatus? No. Your sodium. So, can you see how when you have shifts in your fluid status, you're going to have some shifts in your sodium? And we'll talk about all that in a minute. Vital signs we're going to monitor for hypovolemia and hypervolemia. So what are our vital signs that we're going to see?
Blood pressure. Yeah.
Changes in blood pressure. Hypovolemia, what would our blood pressure do? Tank. Yeah, what about our heart rate? Increase for compensation. I know you've heard this. It's like a drill sergeant keep telling you the same thing. What about hypervolemia? What is your blood pressure? Yeah. Weight intake and output. Recent changes in weight. So if they're starting to gain a whole bunch of fluid or a whole bunch of weight, that's a concern, right? And what if they're losing weight? So I like this because 2.2 pounds or 1 kg is equivalent to 1 liter of fluid. So if only we could just lose 1 liter of fluid. I'm just kidding. All right, and then client family education. So it's important at this time when you're talking about these disease processes, foods that can kind of increase your diuresis. What's some foods that can increase diuresis? Coffee, caffeine. So I know everybody probably drank caffeine prior to class. Yeah, caffeine is a natural diuretic. Watermelon, because it's got water in it. So just some client and family education. We'll talk more about it when we talk about the actual disease process. So without even going into our actual disease, you know way more than what you think you guys know. So on the exam questions, when you see these big scenarios that we give you, kind of I just want you to pick out the big key parts, and then you'll be able to answer it just based on like the foundation knowledge you guys have. I believe you. All right, so these are some normal ranges. These are what we're going to be talking about. So we have our serum, which is what serum is. It's just your blood. And then your urine. So your serum antidiuretic hormone, your normal lab value is 1 to 5. Your serum sodium, you should know these, is 135 to 145. Your serum Oz, again, I'm shortening osmolality to Oz. That's also what you're hearing in the clinical setting. To 275 and to 295. And then we're going into our urine. So this is what we're excreting. Your urine Oz will be 300 to 1400. Urine specific gravity 1.005 to 1.030. And then your urine output 1 to 1.5 liters or 30 mLs per hour. All right, so these are just normal values. I just want you guys to know because it'll help you if you know your normals when you see abnormals. All right, we're going to talk about diabetes insipidus, or also known as DI. So there are 3 types according to the cause. Neurogenic is the one I'm most familiar with. We have nephrogenic and then psychogenic. So who can tell me what psychogenic DI is? Yeah, you have a compulsive water drinking. So these patients typically have a psychiatric disorder where they feel the need to compulsively drink water. I mean, they will drink 5 liters of water daily. And I don't know about you, but I struggle drinking, 2 cups of water daily. So this is that psychogenic. That's primary polydipsia. That's not as common, and I've never seen this because I don't work psychiatric, but I'm just throwing it out there that it can occur. Nephrogenic, so this is your inability of your kidney tubules to respond to ADH. So you have ADH, your kidneys just aren't responding to it. So you have a decreased absence ADH receptors, kidney damage, some medications. What medications do you think can cause this? So antibiotics, so your tetracycline type medications are very potent to the kidneys and can cause this. So one of your tetracycline medications, antibiotics. So you have plenty of ADH circulating, but your kidneys, remember I told you how the kidneys work by the renal tubules, they're just not able to excrete it. And then this first one right here is what we will be talking about the majority when we talk about DI. And it is ADH deficiency caused by damage to the hypophyseal system, which is a very long word for just basically your pituitary system. You have head trauma, so increased ICP, talked about that last week. So what's some signs of increased intracranial pressure? Yeah, so what is that?
Cushing's.
Cushing. What else? What can indicate increased ICP? LOC changes, seizures. So any of those neuro changes that you see could cause increased ICP. A brain infection. So what's a brain infection? That's very common that you guys are aware of. Meningitis. Yes. A pituitary tumor. Why would this cause it? It's compressing. Your body doesn't know what to do, so it's either going to release hormone. And then neurosurgery, so that's some type of brain surgery. So a lot of the times, especially in my line of work, you will see central neurogenic, but there is other causes that could cause DI. They're all going to present the same. You just have to look at what the patient's mechanism of injury and what their kind of scenario is. All right, central DI. So abrupt extreme diuresis caused by lack of ADH. So let's just break this sentence down slowly. So abrupt extreme diuresis caused by lack of ADH. So what is our ADH? Antidiuretic hormone. What does antidiuretic hormone do? Yes. So if you have a lack of it, what do you think you're going to be doing? You're going to be peeing a lot because you have nothing in your body telling you to retain some fluids. You're just going to be pouring fluid, right? So does that kind of help simplify what DI is? So your diagnosis is going to have hemoconcentration and dilute urine. So you're going to be peeing out so much water without diuretics. So these patients are going to have, you're going to see a liter of urine per hour without the use of diuretics. So you have to have, without diuretics, a fluid challenge. So that means us giving a ton of fluids, obviously, or hyperglycemia, because hyperglycemia can increase fluid output. So when we have a fresh trauma patient that comes in that was resuscitated with 3 liters of fluid and they're healthy otherwise, they have good working kidneys, if they start diuresing a whole bunch, do you think, and they have a head injury, do you think that's initially central DI? So what's our criteria? Without a fluid challenge. So we resuscitated that patient with 3 liters of fluid. So initially when you see a head trauma patient and you know for a fact that they were resuscitated with a ton of fluid, don't automatically assume DI. So you also have to meet these lab criteria to meet DI. So we have 1, extreme diuresis. So these patients are pouring out of their Foley catheter. They're going to have a sodium greater than 145. Why? Yeah, your sodium is like hanging on for dear life. It's in your bloodstream saying, "Where's my water?" So your sodium is going to be driven upward. Serum OZ, so that is your blood, is going to be greater than 295. Why? It's concentrated. Your urine, so you're peeing a whole bunch of water out, is going to be greater than 300, and then your urine specific gravity 1.005 because you're very concentrated with water. So our treatment for these patients, what's going to be our primary goal? Yeah, we're going to replace our fluids. We're going to use a hypotonic solution, but remember these patients are, especially in our central DI, these patients are going to have head trauma. So you have to play a mind game or kind of a balance between cerebral edema and replacing fluids with your hypotonic saline. And then the number 1 medication that you will give if you work in a neuro ICU, or if you work in any ICU that the patients get DI is DDAVP, desmopressin. So you will give this medication. You can give it PO, oral, you can give it IV. It's given any route. So DDAVP is your medication for your central DI. Some complications, constipation, why do you think that? Yeah, so you don't have enough fluid, so the large intestines, the intestines kind of absorbs that water. And with every water being excreted, you don't have that water to absorb, so you're gonna have constipation. Hypotension and hypovolemic shock, why? Yep, so you're gonna have a decrease in fluid, so decrease in perfusion. Seizures. So it's gonna be because of your elevated sodium. Decreased level of consciousness again goes with your sodium because your sodium's through the roof. You have no water. And then this can also result to death, so you can see how treatment's very, you need to get it treated pretty quickly. So to kind of recap, diabetes insipidus, DDAVP, so it kind of pulls that fluid back into the interstitial space, and this is your actual natural vasopressor, so your ADH hormone that kind of helps with that. So, recap, DI, you're going to have too ADH? Too little, right? So you're going to have not enough ADH, either caused by three main causes. What are the three causes? Yep, psychogen? Yep. Perfect. Your fluid, your labs are going to be high sodium, and your treatment's going to be desmopressin, so your DDAVP, replace fluids, kind of that seesaw between fluids and not, but luckily that is on the provider, not you guys. And then some complications is just signs of dehydration. All right, do you guys understand? Get DI.
So, the other two types of enzymes, those two, you're not going to worry about that.
Well, you're going to treat these patients all the same because they're all going to present the exact same way. But technically on these, if you treat the underlying cause of why the kidneys are damaged or why these patients cycle, why they think they need to drink 5 liters, then if you treat the underlying cause, then it typically treats itself. But if they were sick enough, you would treat them. You would treat their underlying cause and then treat them this way. If that makes sense. So remember, you're messing with your antidiuretic hormone right now. So that saying is true, but when it doesn't have effective hormone regulation.
I was wondering how we get this.
It's a completely different opposite of mindset, but that is because you're messing with this antidiuretic hormone. All right, here is just a simplified pictures for all those visual learners out there. Yes, Jordan. Yeah, I've been in similar situations where you've had to kind of stop fluids because their edema is just so much worsening. And their sodium's driven up through the roof. So it's kind of the neurosurgery. Typically neurosurgery is involved in these patients, and it's their call. Luckily, you as the nurse, you don't have to make that call. So look at your lab value right there. So because you've got, so you're looking at your urine specific gravity, so it's concentrated with water in your urine. So, yeah. Your blood, your serum was what's concentrated. Does that make sense? So when you're thinking of these, your urine and your serum and your urine's different because you're retaining within the serum and then you're drawing out within the urine.
Do we have dilute urine?
Because you're filtering all these kidneys. Yeah. Exactly. Good. All right, so diabetes, this is just kind of another picture. So history, your 3 causes, kidneys, remember, renal tubules. Signs and symptoms, these patients, 20 liters of urine a day, you're gonna have a decrease in specific gravity, decrease in Oz. They're gonna be complaining of thirst because they're dehydrated, right? And then just your nursing care is over on this part. So do you guys feel comfortable with DI? Here is just another picture. You can remember the acronym DILUTE, so dry, nursing intervention, I's and O's, daily weights, because they're probably gonna lose a bunch of body weight. Remember how much one pound of that is. Low specific gravity, urinates lots, treats, you want to treat with the pituitary hormone, so your vasopressin, DPAVP, and then rehydrate. And then just another picture, so for all you guys that need to learn visually. All right, do you guys feel comfortable with that? All right, we're gonna move on to the complete opposite spectrum now. So I want you to know DI, and now we're gonna switch total views. So we're gonna go to SIADH. So this is an excessive amount of ADH. So what's ADH again? Which is retaining fluid. So we got an excessive amount of this causing dilutional hyponatremia. So it's going to be complete opposite of our DI. So it causes same as DI, so our head injury, and then it's got this oat cell carcinoma of the lungs. So sometimes patients that have lung cancer can present first thing with this SIADH. This can be their first symptom. And I can speak on this because my grandmother has lung cancer, and her first symptom was she presented with SIADH. So diagnosis, hemodilution and concentrated. So you're gonna have a sodium that's low. Why? Yeah, because you have excess fluid, so you're gonna have low sodium. Your serum Oz 275, and then we're gonna go to our urine Oz, which is greater than 100. Urine specific gravity is greater than 1.030. So we are peeing out our electrolytes and retaining our fluid because our renal tubules, our ADH, we have too much, so our renal tubules think that we need to retain all this fluid. So we're retaining fluid. These patients are going to present overloaded. So our treatment, if they're presenting overloaded, they have too much fluid on board. What's your number one thing that you guys know? You can give diuretics, so you'll see Lasix being given on these patients. Fluid restriction, they're gonna be taking less than 1 liter per day, and you will see in the hospital, I don't know if you guys have already seen it, but they will have a monitor strict I's and O's on their door or above their head. And you'll actually have to put what they had to drink. I don't know if you guys seen that yet. Hypertonic solution. So who can tell me what hypertonic solution is? Yeah, so this is typically your 3% saline, which is a very, very dangerous type of saline. So you have to give it slowly. Why? Yeah. Yeah, you can cause, yeah, exactly. You can cause demyelination of the white matter, which once these patients demyelinate the white matter, you are comatose and dead. So that is why we have to give these saline very slowly. So you will have, anytime you have a hypertonic solution ordered, you will have both either the neurosurgery that ordered it or a renal doctor, a nephrologist on board, because it's such a high risk medication. Diuretics, so yeah, you're going to be like being given. Vaprazole, that is a medication that's commonly given for SIADH. And then head of the bed flat. So why do you think this? Yep, so it will increase your venous return, help with to release your ADH. Complications, so what happens when we have a very, very low sodium? This goes back all the way back to PACO. Seizures, yeah.
They have to lie flat.
So it helps with their venous return. So when you're laying flat, it'll help with your venous return of your
Is that part?
It helps, so when you increase ADH return, it helps release ADH. So that's,
So we have,
well, it'll help kind of keep them informed, if that makes sense. It doesn't make sense.
so do we have to look wrong anymore?
So it helps like just to limit, oh, I said that wrong. It helps to decrease ADH release.
Okay, now.
Sorry. Now do you understand?
How do you find something about?
It's very hard.
Yeah.
It's hard. So a lot of these times it's kind of an NCLEX thing. A lot of the times these patients will be sitting up in the bed because they're going to have crackles in their lungs. So of course you want your respiratory status to be your priority versus your ADH, trying to suppress ADH secretion. You're welcome. Of course you're going to want to do respiratory before. So if there are crackles, you're not going to land flat. So complications, a low sodium. Seizures, yeah, what else? Yeah, they are decreased LOC, cerebral edema, coma death. So if you have too low of sodium, you can actually, patients can become comatose and die. So this, you have to treat it. Can you raise your sodium very high, very fast? No, she was like, no.
Does that decrease sodium that causes, well, in the brain?
Yeah, they can.
This all too long.
It's because of these hormones, I know. So, because you have this decreased sodium, cerebral edema, coma, death. All right, let's recap. What is SIADH? We have too much ADH, which is causing dilutional hyponatremia. So you've got your water and you've got too much sodium. So your sodium in your blood's going to be, what is your sodium going to be? Low. Your serum Oz, which is your blood, if you're retaining. Urine. Exactly. Our treatment for our SIADH is hypertonic solutions. You're going to have probably neurosurgery, nephrology on board, restriction of fluids. If these patients are awake and talking, you're going to have a sign above their door that says strict eyes and nose monitoring, and you're going to monitor your eyes and nose. You're going to do daily weights. Faprazole, if ordered by the physician. Faprazole, it helps with your ADH. And then complications, so I just want you to be aware of these complications that can occur if your sodium gets too low. All right, so to kind of recap the two. So, look, he is like more than overload, he's drowning in himself. So, there's 7 S's in SIADH. So, how I remember this, I was with a very fantastic neurosurgeon. I apologize. I get to work beside him because he is amazing. He told me, so your SIADH, so with that I, you're going to have an increased ADH. So it helped me remember. So I don't know if that guys helps you, because at first when I learned these two concepts, I was just like, oh my gosh. Because it's, like I said, it's completely opposite of what you guys have been taught. So increase ADH, and you have that I, so that's how I remember my SIADH. So there's 7 S's, so you're going to stop urination, so you're going to have low urine output. You're going to be completely drowning in water, right? Because you have too much ADH. You're going to have very sticky and thick urine because you're going to have a high specific gravity, because it's going to be, it's going to have no water in it, so that's why it's very thick. You're going to be soaked in the inside. So you're going to have a low osmo, and you're going to have hyponatremia. Sodium low, so headache's a very early sign of this because you start seeing those neuro changes. Seizures, so that's an NCLEX said. Keywords, headache, confusion. So when they start complaining of headache, confusion, draw sodium, especially these patients draw sodium. If it's too low, notify a physician. Severe high blood pressure, why? You're gonna have too much fluid. Look how overloaded this little man is, or big man. You're gonna stop all fluid, give salt. So sometimes you'll actually see these patients will have salt tabs. And then sometimes they'll even have like little salt packets, and it looks like salt packets that they put in the water. And then diuretics, so you will see Lasix being given. No IV or drinking, and then 3% saline. So with our 3% saline, it's a very high potent drug, can cause cerebral edema if not careful. So we're gonna have 2 physicians on board, our brain doctor and kidney doctor, really, to simply put it. And to eat salt, which sounds kind of counterintuitive. You've never been taught to tell patients to eat salt, but these patients, if they have a low sodium, you're gonna tell them. I've seen a sodium in the 97. That was a very sick cookie, so. All right, so this is a little song that Dr. Altman placed on the sled. I think it'll help you. I'm not gonna sing it. I'm a terrible singer, guys. You don't want to hear that. But I did kind of rhyme it in my head before class, and it really did actually help. So you can associate it with some type of song, and on your exam, we'll be like seeing you lip sync these songs. All right, so let's kind of do a recap. What is your DI? Not enough ADH. What is ADH? Antidiuretic hormone. What is our sodium going to be? High. What is our treatment going to be? Fluids. DDAVP, vasopressin. Good. All right, and then completely swap it. SIADH, so SI increase ADH. So you're going to have too much ADH, so you're going to be retaining fluid. Yep, so these patients are going to present overloaded. And what's our treatment going to be for these patients? Fluid restriction. Give them salt. Yeah, give them salt. Yep. Yeah, like little Vienna sausages or whatever. Those are not good for you. Here's just another kind of to help you. So SIADH, your oat cell carcinoma. Sometimes these patients, like I said earlier, they present